Hello, my name is George Papachristou. I am an advanced endoscopist and a professor of medicine at The Ohio State University. And along with my colleague, Dr. Samuel Han, who is also an advanced endoscopist and an associate professor of medicine at the Mayo Clinic in Rochester, Minnesota, we will be discussing a very important study that was just published in the Gastrointestinal Endoscopy Journal. The title of our study is The Impact of Difficult Biliary Cannulation on Post-ERCP Pancreatitis, and this is a secondary analysis of the SVI trial. As a background, the SVI trial, or stent versus indomethacin trial, is a recently completed NIH-funded multi-center randomized control trial that included 20 centers within the US and Canada. We were able to enroll approximately 2,000 high-risk patients undergoing ERCP, and those patients were randomly assigned into two different arms. One arm was administration of rectal indomethacin alone, and the second arm was administration of indomethacin plus prophylactic pancreatic duct stenting. The SVI trial was an enormous effort that required 8 years of enrollment to be completed between 2015 and 2023. As far as the primary results of the trial, we found that approximately 15% of the indomethacin arm developed post-ERCP pancreatitis versus 11.3% of the combination arm. And this difference was statistically significant, meaning that the indomethacin alone arm was inferior to the combination arm for preventing post-ERCP pancreatitis. The primary results of our trial were recently published in the Lancet Journal in January of 2024. And now, of course, going back to our feature study, the impact of difficult biliary cannulation on post-ERCP pancreatitis, I would like to ask you, Dr. Han, could you briefly describe the design and the results of our study?
Thank you so much, Dr. Papachristou, for that introduction. So this was a secondary data analysis of the stent versus indomethacin trial, specifically looking at participants in the trial with intended biliary cannulation attempt, which was the vast majority of participants. And our primary goal was really to elucidate which aspects of a difficult biliary cannulation confer the greatest risk for post-ERCP pancreatitis, as detailed ERCP reports were completed for each participant. So in the study, we did find that 84.1% of participants had a difficult biliary cannulation, which was defined a priori as having greater than or equal to 6 cannulation attempts or greater than or equal to 6 minutes spent cannulating. We then created 3 subgroups to try to delineate the different levels of risk based on the cannulation difficulty and pre-procedure risk factors. So as you can see on the screen in the figure, one subgroup was those with a difficult biliary cannulation and a high pre-procedure risk profile for post-ERCP pancreatitis, which included any of the following indications: biliary sphincter Bode dysfunction, pancreatic sphincter Bode dysfunction, pancreatitis, or recurrent acute pancreatitis. Additionally, participants were considered high risk if they had a clinical suspicion of sphincter Bode dysfunction, had a prior history of post-ERCP pancreatitis, or females less than 50 years of age. Another subgroup was those with a difficult biliary cannulation without a high pre-procedural risk profile. And the last subgroup was those with a high pre-procedural risk profile, but without a difficult biliary cannulation. In essence, as seen in this next figure, the highest risk of post-ERCP pancreatitis was seen in those with a difficult cannulation and a high pre-procedural risk profile with a rate of 20.7%. The next highest post-ERCP pancreatitis rate was seen in those with a high pre-procedural risk profile without a difficult biliary cannulation at 13.5%. Lastly, the subgroup with a difficult cannulation without a high pre-procedural risk profile had a pancreatitis rate of 8.8%.
Thank you, Sam. And if you were to think of our study, what does exactly our study adds to the existing knowledge that was already out there?
Yeah, I think there are a couple of key findings in addition to the different rates of post-ERCP pancreatitis that we found. So in terms of intraprocedural factors, the number of wire passages into the pancreatic duct was significantly associated with post-ERCP pancreatitis, with the risk of pancreatitis increasing proportionally with the number of wire passages, as seen in this table here. Notably, pancreatic duct contrast injection, performing a sphincterotomy, and the type of IV fluids administered were not associated with post-ERCP pancreatitis. Importantly, the combination of rectal indomethacin and prophylactic pancreatic duct stent placement was associated with a reduced risk of post-ERCP pancreatitis. And when stratifying the risk of post-ERCP pancreatitis by the number of wire passages, the benefit of pancreatic duct stenting becomes clear, as seen in this figure that you see here. Importantly, even with just one wire passage into the pancreatic duct, you can see the benefit pancreatic duct stent placement provides in mitigating the risk of post-ERCP pancreatitis.
Great. And looking ahead, what you feel are the next steps and questions that are still unanswered and we really need to work on moving forward?
Yeah, so while this study provides further insight into the different components of a difficult biliary cannulation, a great amount of work still needs to be done to determine the inflammatory pathway by which post-ERCP pancreatitis propagates. Only then can we perhaps determine other prophylactic therapies that help us bring down the rate of post-ERCP pancreatitis closer to 0%. We also need to figure out how the temporality of events play a role. So for example, if we place a pancreatic duct stent early on in the procedure, is it more protected than placing a PD stent late in the procedure? Importantly, we also need to determine biomarkers for post-ERCP pancreatitis that can be identified pre-procedure so we know who is truly high risk for post-ERCP pancreatitis. And lastly, while we had 3 subgroups that represent 3 different levels of risk for post-ERCP pancreatitis, the SVI trial did not include the lowest risk group, which is that of those with a low pre-procedural risk without a difficult biliary cannulation. And that remains a major limitation in determining just how much difficult cannulation contributes to post-ERCP pancreatitis.
Great. Dr. Han, thank you so much for your insightful answers. And this now will conclude our video. Thank you all for watching it and have a great day.